So we're going to move to the Ferenc Jolesz Award, which we announced yesterday, but want to do the award recognition and the talk today. So it is a great honor to present this year's Ferenc Jolesz Award. And the Focus Ultrasound Foundation and Insightec put together this award. It gives us another opportunity for us to remember Ferenc, but also to introduce him to the younger generations of scientists and researchers that are joining the field and were not fortunate enough to work and know Ferenc. The field of focus ultrasound has been blessed with many visionaries and pioneers that paved the way of this therapeutic modality and its pathway to the bedside of patients. Ferenc was a mentor and a guiding light for many of us. He was born in Hungary and arrived to the US in 1979. He was a neurosurgeon by training and got a residency position at the Department of Radiology at Brigham and Women's in Boston. In the later decades of the previous century, medical imaging technologies have shaped their way to become a common necessity in medicine. Ferenc was a big part of that, as he realized the huge potential for improving patient care through advanced imaging and diagnostics. Ferenc's personal ambition was to take things beyond what others do and push this technology and imaging technology and innovation to the extreme to keep making things better. With his spirit, he envisioned that the emerging MR imaging modality would not be limited to diagnostics, but can play a huge role in delivering therapy. He was one of the founding fathers of image-guided therapy that became his passion and legacy. He encouraged and motivated MR vendors, scientists, physicians, clinicians, that image-guided surgery is the ultimate way to deliver therapy to patients. In the late 1990s, as focus ultrasound technology developed with the introduction of multiple phased array elements and advanced beamforming electronics, combining non-invasive therapy with non-invasive imaging became possible, and Ferenc was a big part of that. In the closing of the last century, Insightec and Ferenc shared that vision, together with many other scientists, physicians, and pioneers, paved the way for developing MR-guided focus ultrasound. For almost 2 decades, we all worked together with him closely to overcome multiple challenges to turn our shared vision into the reality we have today. Ferenc was our guiding light. He was there in our most glorious successes. He was always there when there were tough moments of despair and uncertainty. His clear vision of the future potential, his determination to see through the challenges and never give up, were a fundamental element in establishing what we see here today in our community. Ferenc left us in 1914. He was fortunate to see this vision, or his vision, translate into a true, robust medical technology, and nothing gave him more joy than seeing the benefit it brings to patients. Ferenc also left us with a legacy to continue to explore, expand, and innovate, to advance MR-guided focus ultrasound to new frontiers, treat more diseases, and bring more help to more patients. The Focus Ultrasound Foundation, together with Insightec, announced the Ferenc Jolesz Award back in 2016 to honor the life achievement of Ferenc and his work. It is intended to recognize and encourage his innovative spirit in mid-career researchers and clinicians who continue to advance focus ultrasound technology in the field. As one can expect with the growing field, the selection process is becoming tougher and tougher from year to year. We are glad to see that the bar is consistently getting higher. This year's selection committee reviewed multiple applications and ranked the runners-up with the right call. The recipient of this year's award, as we announced yesterday, is Dr. Graeme Woodworth, who is here with us today. Graeme is a professor and chair of neurosurgery at the University of Maryland School of Medicine and a director of the Brain Tumor Treatment Research Center. His pioneering work in neuro-oncology set the stage for some of the most important advancement in the field. His exceptional academic work spans from basic mechanisms studied in the lab and in translational research, and all the way to the multiple clinical studies he designed and developed and treating patients in these trials today. Graeme will share his work after this talk. I want to thank the Focus Ultrasound Foundation for helping us recognize Frank and keeping his spirit with this technology and this community and society. I want to thank the selection committee for their hard and diligent work in selecting the candidates. And thank you again for putting this venue together in experimental or non-experimental format. And we look forward for an exciting week.
Maybe we can pull up the slides. Thank you very much, Yael, and thank you, Neil, and the selection committee for this great honor. I'm really excited to be here in person with you all today. I remember coming to this first symposium many years ago and thinking about how exciting this technology is and what a great opportunity we have with the Focus Ultrasound Foundation and Neil Cassell's leadership really taking this technology into the clinical environment. And it's always been Neil's vision that the Focus Ultrasound Foundation is really about clinical translation. And while mechanism and understanding the biology of these effects is very important to designing the treatments that we'll see more about this week, I think that your vision, Neil, for taking us into the clinical environment is really what is at the foundation of the spirit of this award and what Dr. Jolesz was really working so hard to do up at Brigham and Women's Hospital. So it's again my honor to be here with you all today, and thank you again. I'd like to share with you some of the work that we put together with the support of the foundation and Insightec, who are helped initiate this award. And so some disclosures, I don't really have any financial disclosures, but some grant funding and some clinical trials sponsored there, some by Insightec, as you can see. So this is a great team, and Focus Ultrasound, as you all know, can't be done with just engineers or just clinicians. It really takes a large group of people, and this is just a subset of people who have worked so hard to be part of the team that we have at the University of Maryland and in Baltimore. And really started with Howard Eisenberg, who was the previous chair of neurosurgery, is here with us today, and his deep connection with Neil Cassell and his interest in image-guided therapy himself. And he and Elias Melhem, who came to the University of Maryland from University of Pennsylvania previously, really helped found the team that really kicked this all off for us in a clinical program at the University of Maryland. But it was also coalescing really nicely with where the company Insightec was at the time in terms of the development of the technology. Many of the foundational elements, again, started at Brigham and Women's Hospital with Dr. Jolesz and Claire Vohinanen and Nathan McDaniel, and a number of the others that are up there, Alex Golby as well. And so all of our work was really done in collaboration with this group. In addition, after Clairvaux had left Brigham and gone to the University of Toronto, the team expanded, and you can see some of the members of that team here near Lipsman and others who are still very intimately involved in this work. So when we think about neurosurgery and interventions in and around the brain, it really starts with an understanding of neuroanatomy and imaging. Again, the foundation of what Dr. Jolesz was trying to do with the advancement of MRI. And in the early 1900s in this country, Harvey Cushing, you can see here, was sort of thinking about neurosurgery as its own specialty, as its own way of intervening within the brain and within the nervous system. And you can see there his relatively rudimentary light on his forehead for a transsphenoidal surgery into the pituitary region deep within the brain, accessing that for the first time. And that was a highly novel, highly risky way to kind of get at a very common problem, a pituitary macroadenoma. Fast forward to 2011, we began to understand the brain in deeper ways with tractography, as you can see here, and being able to intervene with tractography using deep brain stimulation and other tools that allowed us to access these deep structures from a surgical perspective. In addition, we also started to use endoscopes, not unlike what Dr. Cushing was trying to do with that light on his forehead. We could take the light and actually put it closer to the pathology and visualize these structures with a high degree of resolution and then intervene in an even safer or more effective way. So around the same time, some of you may have seen this article in Time magazine, maybe Neil Cassell saw this. But the editors in the invention issue envisioned a coalescence, a merging of two exciting technologies, magnetic resonance imaging and ultrasound. And if these two could come together in some way, this could be truly life-altering, life-changing. And really, that is where the foundation of this award and what Dr. Jolesz's career was all about. It was about merging intervention with high-resolution imaging and intervening in a way that was more effective for patients, safer for patients, maybe even lower, shorter recovery times, things like that, which are very important, especially in today's world. So again, in honor of Dr. Jolesz, as Yael mentioned, this was a true pioneer in the field of image-guided interventions. You know, we think about this now as commonplace. We think about endovascular procedures in neurosurgery. We think about stereotactic procedures for functional neurosurgery. We think about what we're all doing in the clinic now with focused ultrasound. This was all a highly novel and uncertain concept back when Dr. Jolesz was pushing it and developing things like this National Center for Image-Guided Therapy in 1995. Developing the concept of the Amigo suite, Advanced Multimodal Image-Guided Operating Suite, that included not only MRI, but PET, CT, ultrasound, and angiography all in one suite. He became a member of the National Academy of Sciences and Institute of Medicine, and really was the first team leader of an MRI-guided interventional suite and program. And his real vision, as Yael mentioned, was about imaging the intervention in real time. So this is a picture, thanks to Nadir and Yael for providing this, of the first focused ultrasound treatment done at Brigham and Women's Hospital in 2005, an ablation of a GBM. And that really set off the work that really inspired me and what we're going to talk about today. Let's see if this will play. You guys have probably all seen this before. Maybe not. Maybe you can press play on that so people can see the... So, as many of you know, this is the Insightec Exablate device, and it allows over 1,000 individual ultrasound transducer beams within a hemispheric array to be individually controlled and be individually adjusted to that patient's skull to focus the beams to a desired site deep within the brain. And this is truly a revolutionary concept, the ability to have so many different energy forms and energy beams coming together, not unlike we use for stereotactic radiosurgery and other forms of intervention in and around the brain, but with ultrasound to be able to do this through the intact human skull and have the effect of thermal ablation with sub-millimeter accuracy was truly astounding. And so this concept and the approval of this device in 2016 in the United States for the treatment of essential tremor really kicked off a whole new understanding of what the possibilities could be for steering ultrasound beams within the brain and having effects, not only thermal ablation, but potentially effects that are mechanical that could have a downstream impact on blood vessel permeability, as Dr. Kanafagu mentioned, or neuromodulation. And so when you take this idea of a subspot and the ability to target almost anywhere within the human brain a small subspot of energy, and also measure in real time the emissions of ultrasound acoustic emissions from that subspot, not only in the terms of understanding a temperature change that could be derived in that location, but also any mechanical feedback, whether that's resonance or cavitation. And then take the ability to not only have one subspot, but steer the energy beam through a grid of subspots, almost like a 3D printer, here represented as a 3x3 grid within the brain, and in real time steer through that grid the energy beams in a very coordinated way and have a desired effect within a region of the brain as depicted there in the frontal lobe. So this is the concept of blood-brain barrier disruption at a lower power, but with circulating microbubbles in the bloodstream and activating those microbubbles in the bloodstream in real time and measuring the effects of those microbubbles. Here we can maybe play this video, not unlike the one we saw before. So here you can see circulating red blood cells and also small microbubbles, gas-filled ultrasound contrast agents that are used in clinical practice for diagnostic imaging. And when these bubbles are activated and they attain a stable oscillatory pattern and expansion and contraction within the blood vessel, that can temporarily disrupt the connections between the cells that form the blood vessel, and this can lead to, as we all know, temporary blood-brain barrier disruption and vascular permeability. So this concept of using standard ultrasound contrast agents and a device that we know can have a high degree of control within the brain really started the idea of starting clinical trials with this device for patients with brain tumors. So here's an example of the first patient treated in the United States with a brain tumor using this device. And what we wanted to do with this technology and with this trial was actually obtain tissue so that we could study the effects of the ultrasound in the actual tissue that was being disrupted. And so here you can see a patient that has a frontal brain tumor. It's a T2 hyperintense, intrinsically non-enhancing brain tumor that after focused ultrasound in one of those 3x3 grids that I showed you earlier, we can see in the far right image there on the MRI, the new contrast enhancement within that desired target. What that allowed us to do was to create a stereotactic neuronavigation sequence that we could use in the operating room to steer to and localize to that area directly and actually resect that area early in the surgery before there was brain shift or any other changes, and actually visualize that with fluorescein dye, which we sometimes use in the operating room to visualize contrast enhancing tissues. And so here you can see that contrast enhancement within that target area and then the tumor resected on the bottom right. So we also wanted to look at these tissues for the direct effects, somewhat crude measure here with H&E analysis of these different regions. And here you can see 4 different regions that were removed from a patient that had focused ultrasound and a control region in that same patient that did not receive focused ultrasound. And what you can see is that there's no significant change, even in areas where we saw some small T2 star changes in the area of the target. So we also looked at some of the indirect measurements of the bioeffects of blood-brain barrier disruption in these regions, and indirect as measured by MRI. So we have contrast-enhanced MRI and also T2 star weighted imaging. And what we see is a correlation, an early correlation between the dose of energy that was delivered to a given target and the bioeffect, more so with the contrast enhancement, less so with the T2 star. This is an area of active investigation with some of our bigger data sets that we have now from the other clinical trials. So the idea here is that this is the type of patient that we really need to do something better for. This is a patient with a glioblastoma, the most common deadly primary brain cancer. Maybe some of you have family members or friends who have had this disease, but the median survival for this disease is around 16 months. There has not been a significant change in the natural history or treatment for this disease in almost 20 years, and these patients are diagnosed and it's essentially a death sentence. So we need to do something more. As surgeons, we can take out that white contrast-enhancing ball of tumor fairly effectively now. We have tools, technologies, both imaging and intraoperative tools that allow us to do this safely. With brain mapping, we can preserve function, and that feels like we're doing something important for this patient. As you can see in the postoperative image, there's almost no intrinsic contrast enhancement remaining in this patient. Patients go on to receive adjuvant chemo and radiation treatment over the next 6 months or so. But often within 12 months, we start to see contrast enhancement within the 2 to 3 centimeter margin surrounding the original resection cavity. And by 18 months, that contrast enhancement has expanded across the midline, and the patient is not going to live much longer. So the idea is, after surgery, the brain may look like this on the MRI scan, a T2 hyperintense region around the original resection cavity with no residual contrast enhancement. And the target that we want to get after is this region where we know the tumor is most likely to occur. This is also the target for our standard of care radiotherapy, which is the 2 to 3 centimeter margin around that original resection cavity. So we came up with the idea of looking at this. Can we open the blood-brain barrier both in the setting of upfront standard chemotherapy or in the setting of recurrent disease and give chemotherapy, a new chemotherapy called carboplatin, an agent that's used for other cancers. And this was the sort of the next phase of clinical trials that were initiated by the team from Toronto, Brigham, and Maryland. And so what we focused on here was looking at the safety and feasibility of treating monthly in the setting of these standard or adjuvant chemotherapy treatments. And that's what we looked at in both the context of upfront and recurrent tumors. So the lingo for this is BT008 from Insightec and BT009. And here you can see the description of the trials and the doses of ultrasound and the volumes that were treated. In the first trial, upfront trial, we treated up to 65 cubic centimeters, and then in the second trial with carboplatin, the dose and the volume increased to about 110 cubic centimeters, so a large volume. So here you can see the enrollment in these trials. You can see in the BT008 study, which the Brigham team treated the last cycle of the last patient last week, I believe. This is data from a few months ago, so this is a few more patients and treatments now. You can see a large number of total treatments in both of these studies, which has created a large amount of data to analyze for both safety, feasibility, and the potential future use of this technology. Here you can see the volume. One of the early issues that we thought about when we got to the point of having a 3x3 grid, which seemed quite small, 1 cubic centimeter, was could we expand this to a large, clinically relevant volume, such as 60, 100 cc's. And you can see here in both studies that we successfully got to that volume, thanks in large part to the Insightec team developing the beam steering capabilities and the power control that allowed this to happen in a very safe and controlled manner. So here's what it looked like in the early days when we could create slightly larger grids of energy or target grids, and then deliver that energy within the peritumoral resection cavity. In the first patient, you can see a resection cavity there in the posterior temporal region, and then the energy delivered. What you see there is a heat map of the deposited acoustic energy over the course of that targeted treatment. And then you can see the new contrast enhancement in the region of those targets adjacent to the resection cavity as designed. Later on in the study, you can see a similar target region in the area around that resection cavity, but what you can see there is a slightly larger grid and target region. And what you can also appreciate there is that the energy deposited is much more homogeneous and not as sort of heterogeneous and spotty across that. And that became a major challenge and goal of the trial, was to advance the technology to be able to create a more homogeneous pattern of energy deposition, and to do that in the region of tissues that are not heterogeneous, or that are heterogeneous and that have a very disparate amount of blood vessels throughout that area. So the microbial density within these areas may be also quite different. So the ability to create such a uniform treatment within this peri-resectional space was a huge advancement, and really, credit should be given to Rafi and Eyal and the entire Insightec team that put this all together. So one of the real foundational elements of this technology is the ability to have a closed feedback loop control of the power cycling through a given target. So you can imagine that those 1,000 plus transducers are steering through this grid in a 3D printer-like fashion through the intact human skull, and attempting to deliver amount of energy in a uniform way to that entire heterogeneous tissue target. So that's quite remarkable to think that that's possible. But this is really how it's done. And you can see the black line there is the average power that's being delivered over the course of this targeted treatment. But what you see in the colored lines is the power controller cycling through the different amounts of power to generate the desired effect based on harmonic emissions or acoustic emissions to a given subspot. So each subspot experiences a slightly different power, all geared to achieve a given acoustic emission pattern in that region. So it's truly remarkable that this is happening on a millisecond level as the system scans through the target that's drawn by the provider or the proceduralist. So here's an example of what that can look like in real time as a patient is actually receiving a treatment. Maybe we can play this video as well. So what's happening here is we've drawn the target in that peri-resectional area of the GBM patient, and the energy is being delivered and cycled through the subspots. You can only see the average power, the green line on the bottom right there. But what you see also is the subharmonic intensity over time, which is the acoustic emissions feedback being delivered back to the system and allowing the system to ramp and change the power to achieve a given intensity. And so over the course of this treatment, you can see the accumulation of that cavitation or harmonic dose in the target region there on the MRI scan. And this is happening for the proceduralist in real time. In addition, we actually have the ability now to monitor any T2 star changes in real time, all under while the patient is receiving this treatment awake. And as I showed you before, this corresponds nicely, and the degree of energy deposited within that target correspond nicely with the desired bioeffect, the new contrast enhancement within that target region. So again, this is the vision, and the hope is that we can now use this technology and treat with volumes in a reasonable amount of time with a high degree of safety in monthly cycles to deliver new chemotherapies, not only the standard chemotherapies like temozolomide, but new chemotherapies such as IV formulations of carboplatin or immunotherapeutic drugs, and maybe even some cellular therapeutics. This is now opening the opportunity for us for the first time to think about localizing truly effective therapies in these areas where we know the GBM cells are most likely to take hold and recur. So I'll show this one last video, just putting it all together. Again, a new chemotherapy here, again loaded in purple there. You can see the blood-brain barrier disruption in a similar way with the expansion and contraction of the microbubbles in the acoustic field. This allows the localized extravasation of the chemotherapy, which is in the blood vessel, into those tissues, as we've shown, can happen with both fluorescein dye and gadolinium contrast enhancement, and then delivering that chemotherapy to the region around the brain tumor. I still do think that it's going to require a resection of the tumor to really make this effective, but again, that technology is also advancing rapidly in the surgical area. So this all, again, started with the vision of Dr. Jolesz and the team at Brigham, and has expanded now to many of us around the world who are working in a similar way with MRI-guided interventions and focused ultrasound. And I really think that we are at a critical next phase of this technology development and in clinical application, where we have the ability to deliver the energy in different forms, thermal, mechanical, neuromodulatory, and do it with a high degree of precision and control with closed feedback loop type monitoring. So again, thank you very much to the team and to Insightec and the foundation for this award, and I'm really excited to be here with you all and to continue the conversation around this exciting technology. Thank you.